At 7:02, so why don't we go ahead and get started? Uh, I'm Kennedy Ringelberg, one of the PGY3s over at the Navy, rotating here for my spine rotation. I have a pretty extensive topic to cover in just a short period of time: spinopelvic parameters and sagittal balance. I know that people have the OR to get to things, so I'll try to keep it brief, but I apologize in advance if it's a somewhat abbreviated discussion of this topic. So when we talk about this a lot during our pre and post-op conferences, so this is honestly a great talk for me to prepare for, just to give me a chance to really kind of delve into the literature, figure out where some of these like numbers and formulas come from that we use when we're talking about surgical planning for these patients. As such, I recognize that all of you probably have much more experience with this than I do, and there's probably a lot more that you can teach me than I can teach you. So I encourage you to keep this interactive. Feel free to interject or add comments or questions wherever you feel is appropriate. Why else is it important? Beyond my own personal edification is there's been a explosion of sort of increased interest in this topic as we continue to attempt to optimize outcomes for our surgical patients. There's been an accelerating number of publications on this topic in the literature recently. So historically, this all kind of began as humans evolved bipedalism, which allowed us to have a greater field of view, running on 2 feet, and it also freed up our hands, which allowed for the more complex development of our brains. And spine developments reflected this evolution of a more upright posture in order to accommodate that. But as such, there's a pretty high incidence of adult spinal deformity in the population, and also some other long-term difficulties associated with maintaining an upright spine. At the center of this problem, Jean Dubuisset initially described the cone of economy, whereby the further someone's spinal axis is from being centered or balanced, the more activation and energy is required to maintain an upright posture. And this can tend to lead to abnormal stresses on the spine, leading to worsening deformity and degenerative changes. And that is oftentimes followed by compensatory mechanisms to try to keep the occiput over the pelvis. What this leads to for patients can be significant pain, fatigue, difficulties with disability, potentially neurologic compromise, and poor cosmesis is something they may also notice. In terms of disability, lots of previous data has been published regarding adult spinal deformity and how disabling it actually can be. This was one such study that basically showed significantly worsened short form 36 scores in patients with adult spinal deformity. And importantly, they basically had the same overall scores as someone with chronic heart or lung disease, just kind of, again, underscoring the significant disability associated with spinal deformity. Taking that one step further, this study basically found a direct and nearly linear correlation between the degree or severity of spinal deformity with functional outcomes, including disability index in the short form 12. This study basically helped to delineate that sagittal deformity itself seems to be more specific and more significant in determining the functional ability of these patients. This study basically looked at the correction of sagittal and coronal balance. And they found that improvement in their sagittal balance was more strongly correlated with improved functional outcomes rather than those who achieved better correction in the coronal plane. So all that is to say that sagittal balance is very important in patients' overall function and quality of life, and that improved balance improves outcomes and should be something that we strive for when we're taking care of these patients surgically. But it begs the question, what parameters should we use to define sagittal balance? What is potentially considered normal, and how can we use this to, again, ultimately guide our treatment plans for these patients? So again, the overall goal is to maintain an occiput over the spinal pelvic axis, again, to allow for more efficiency in maintaining an upright posture as described by the cone of economy. In most patients consists of a natural thoracic kyphosis with corresponding lumbar and cervical lordosis. These can further be broken down. But overall, sagittal balance can be described relatively simplistically by the sagittal vertical axis. But again, this may be an oversimplification of their overall sagittal balance, and there's lots of factors that contribute to this. I mentioned the natural lumbar lordosis.
What's one fault in using SBA just by looking at it?
It can be affected by patients, I wouldn't say their posture, but how they're positioned during the X-ray.
Actually, what does it not incorporate?
It doesn't incorporate the rest of the cervical spine.
Right.
Either.
Yeah. So it's not a true measure of
right.
global alignment. It's just a plumb line, basically, right?
Yeah.
So from the shoulders.
So I mentioned lumbar lordosis, but this can be further broken down segmentally. And an important parameter that we tend to focus on is the lordosis achieved from the L4 to S1 level. Typically, this accounts for approximately two-thirds of a patient's lumbar lordosis, and that's important to keep in mind. Thoracic kyphosis can also be measured as a whole or in segments, and typically the degree of thoracic kyphosis is approximately 3/4 of the lumbar lordosis present. These measurements of the spine are helpful, but sagittal balance all begins in the pelvis. And these are the kind of classic historically relevant parameters that we look at with all of these patients, which include sacral slope and pelvic tilt. And then when you combine those measurements, that gives you the pelvic incidence. I won't belabor those too much. You'll just be pretty familiar with it. This paper basically looked at these radiographic parameters and tried to standardize what was considered "quote unquote" normal from patients, and they came up with some of these values, which I think are still a general guideline that's relatively accepted, but again, it tends to be more complicated than that. This was a paper published in 2010 that again sort of tried to delineate from these normal values how to best go about planning for surgery to achieve spinal harmony, again, keeping the occiput over the pelvis. And the general numbers that that are usually accepted is a pelvic incidence and lumbar lordosis mismatch of less than 9 degrees, pelvic tilt of less than 25 degrees, and a sagittal vertical axis of less than 5 centimeters. This paper just kind of goes on to basically underscore the importance of these measures, and basically found that once you hit those thresholds, as the deformity progresses, there's an increased risk of adjacent segment disease after correction. And importantly, if pelvic incidence and lumbar lordosis mismatch is over 11 degrees, there's basically an extremely high rate of adjacent segment disease. This study is a subset of patients specifically with lumbar stenosis and grade 1 spondy, and they were basically trying to determine whether or not fusion was indicated in patients by breaking them down into whether or not they were "quote unquote" balanced based on pelvic incidence and lumbar lordosis mismatch. They basically found that those with a high mismatch did better with fusion versus those with a low mismatch. So those that were relatively more balanced in these parameters actually had better outcomes with just decompression alone and without fusion. But even with this understanding, this is an example of a study that basically demonstrates there are other equally important factors in achieving overall sagittal alignment, and that simply using pelvic incidence, lumbar lordosis, sagittal vertical axis may be oversimplifications. And furthermore, they kind of, again, delineated these thresholds, which may be a little bit tighter than what was previously described. So Beyond this, analysis of sagittal valence parameters have become much more comprehensive, and that an important part of this workup was started by Roussel when he proposed his classification in 2005, which basically attempted to describe what are considered normal lumbar phenotypes in a patient population that is asymptomatic. And this starts with defining the sacral slope, either as less slope versus a more normal slope, which is considered between 35 and 45 degrees, and those with increasing slope. And then beyond this, basically, where is the apex of lordosis or the inflection point? And then using this to, again, basically describe these patients in terms of these 4 phenotypes, what they came up with. Type 3 is what's kind of considered the normal with a moderate amount of slope and then a balanced lordotic curve. Further work basically allowed him to basically define some of these lumbar parameters based on pelvic incidence. And these are some of the formulas that he came up with, which still kind of guide our work and did kind of lead to the simplification of a lumbar lordosis and PI mismatch of less than 9 degrees. But it's expanding upon this knowledge. Again, Roussel and his group did a retrospective review of 331 patients with degenerative changes in their spine. And they basically tried to further characterize degenerative patterns to propose sort of an evolution pathway in these degenerative conditions. They described 11 subtypes that came from his original 4 normal phenotypes. And all this was basically an attempt to see if we could determine what is normal for patients, be able to identify their degenerative patterns, and then correct those degenerative patterns to try to get them back to normal to improve their surgical outcomes. In practice, this has been employed relatively successfully. This was a retrospective review published in 2020. They noted that 66% of their patient cohort was corrected to what was considered normal based on the just discussed degenerative classification proposed by Roussel. Importantly, the risk of mechanical complications, which included non-union, proximal junctional kyphosis, rod fracture, or implant failure, was significantly higher in those where normal alignment was not achieved compared to those who were restored to what was considered their normal Roussel classification. And there's an odds ratio of failure of 3. Similarly, this was a study also done by Roussel's group that attempted to basically define rates of proximal junctional kyphosis based on 4 different methods of correction, one of which included trying to restore what was considered their normal Roussel phenotype. And it turns out that returning them to their normal Roussel phenotype was most strongly correlated with reducing the incidence of proximal junctional kyphosis with an odds ratio of 4.6 for those who did not achieve their normal alignment according to this classification. One concern about some of these parameters is that they aren't necessarily fixed in patients and are also not necessarily directly modifiable in surgery. So this was an international effort that included work from Dr. Mike Kelly, but they attempted to basically define more detailed spinopelvic parameters in healthy asymptomatic adults, and basically try to find things that are more directly modifiable in surgery that we can actually control. They found that the L1 pelvic angle and T4 pelvic angle, which is considered part of the T4 L1 hip axis, was most directly correlated with appropriate sagittal alignment. They also were able to use this extensive database to basically make predictive models for determining what should be considered ideal lumbar lordosis, L1, and T4 pelvic angles based on their pelvic incidence. And this is an example of one of the charts that's come from this data set to basically help us define goals for these parameters intraoperatively and also for surgical planning. They do point out that there's no long-term data on sort of using these predictive models, but I do think it's something that is important to consider during surgical planning, and it's something that we use a lot. Other important factors to consider when we're treating these patients includes age, and there's been a good amount of literature that demonstrates that normal parameters do change as the age of the patient changes. This was an attempt to characterize normal parameters in patients of different ages, and from this data, they were able to propose certain goals, again, based on a patient's age. And this is one of the charts from their study. Important trends to point out just include that pelvic tilt, PI or pelvic incidence and lumbar lordosis mismatch, and sagittal vertical axis measurements do tend to increase over time.
What's the difference between this and the means data? The last paper you presented. One key critical difference.
I'm not sure.
What's the patient population of one versus the other?
Was one with deformity and one without?
Yeah, this is with deformity.
This is without.
So they're defining normal age parameters based on deformed patients.
Mm-hmm.
It's a flaw.
Yeah.
So those of us that don't believe this data would say, hey, like, doesn't totally make sense to say that we're targeting thresholds that are from a group of patients that are deformed.
Mm-hmm.
Rather than saying what's the general population, it's normal without deformity and arguably without pain.
Mm-hmm.
What do they look like?
Yeah.
Okay. That's what means that the last group they looked at like patients without spine pathology across ages.
Yeah. So to validate this was another study that was done, basically looking at, again, the amount of correction in patients is broken down into different age brackets. And they looked at 1 year postoperative alignment data, and they basically found that there was an increased rate of proximal junctional kyphosis in the older subgroups. And this was thought to potentially be due to an overcorrection, even though they kind of, for the most part, achieved their goals according to sort of the methods that have been described. The older patients tended to have worse outcomes. And again, this is thought to kind of be due to the fact that maybe we need to be a little bit more lax on our sort of corrective goals in older patients.
I'll harp on you again. So what year is this?
2017.
Okay, what year was the data collected?
Much earlier.
Yeah. So then the alignment targets back then were this PIL concept, right? Which we now don't put that much.
Right.
So you're seeing it, you may have achieved your alignment target,
right?
But if you didn't get your distribution of your lordosis right, then you failed. So like, these are great historic articles, and I think they're important because it showed like the progression over time. But
yeah,
I would say like this is where it's really important that you know the data sets more than the conclusion. That makes sense. Like, what were surgeons thinking at the time to figure out, all right, why did that actually happen?
Yeah. Okay.
Good. We don't know the answer to it in that data set. They didn't look at it, right?
Yeah.
I wish they could just go back the same data sets and the different targets and compare. That would really set the answer.
Yeah, I think Renaud's done some of that. Okay.
So all this is to say, there's a lot that goes into planning for these surgical patients. There's a lot of factors to keep in mind and consider. Again, I don't think the conclusions of any one of these studies should necessarily be sort of taken as gospel, but are all just important factors to keep in the back of our mind. But one thing that I did find kind of interesting is even though we have all of these tools and goals to help us try to achieve the best outcomes, there was this paper published that tried to describe how successful we are as surgeons in actually achieving and executing our surgical plan. They basically found that in some of the parameters or in at least most of the parameters, they were not able to achieve their stated goals, and were not able to achieve all three, that is pelvic incidence and lumbar lordosis mismatch, sagittal vertical axis alignment, and thoracic kyphosis in a good majority of patients. That is to say, we, again, have all these tools, but I think it's very important, just as somebody who's very early on in my career, to always be sort of my own worst critic and try to learn from basically every case that I do.
Kennedy, it's my job to be your own worst critic.
And I appreciate that too. So again, this is kind of a very simplified talk. It's a very vast topic that we could dedicate hours of discussion to. But overall conclusions and things that I took from preparing for this talk is that sagittal deformity is a significant cause of morbidity and disability in our patient population. These sort of historic goals of pelvic incidence lumbar lordosis mismatch of less than 10, SBA of less than 4, and pelvic tilt of less than 20 are important, but again, not everything when it comes to correcting sagittal deformity. I do think we put a good amount of emphasis on the Russell classification and other spinal pelvic parameters, which does show promise. Also important that age matters. I think also important to keep in mind, and this is something that one of our attendings over at Balboa has said, is that all adult spinal cases are adult spinal deformity cases, no matter what they're truly for. So important to keep this in mind for any patient that we operate on. And then lastly, again, sort of underscoring me moving forward is to always critique myself and learn from our past work in order to improve things moving forward.
That's a great thought.
Mike or David, what do you think about point number 2 and its subpoint?
Historic sort of guidelines that I think we still don't truly understand what. I mean, pelvic tilt, compensatory balance, sagittal, it's a proxy for your global alignment. GL mismatch, there might be some validity to not being further off than being closer, but it doesn't capture the whole picture, I think. And we still probably don't understand the whole optimal alignment goals. But the Russell has definitely helped us think about it in groups rather than one specific target.
Yeah, I agree with that. I think my take home would be that we just don't completely understand it despite the knowledge that we have this far. I feel like it's all kind of a continuum of like, this is what we knew before, this is kind of what we know now, and then we kind of realize something new. And the problem is, I feel like the patient population is a moving target because they're aging, the treatments are different, the decompressions are different, everything, it's kind of like we're trying to catch something that's moving. But also on the fact that some surgeons are not able to get their goals, I think as things like UNID and SMIO start to kind of get rolling, and then we'll kind of get better insight as to where are we missing, and how close are we actually getting. So I think that'll be more of a objective kind of data.
Can I dovetail on that, Stephen? I think it's important that those things are developed because people that are really locked in on this will have a better understanding. I think another really important part of this whole project is making it accessible to surgeons that are in the community and don't have fellows, or maybe don't have the access to like thought leaders in the space like we all do. So hopefully that'll be something we see over the next 10 years as well, a way to make it more accessible to every just like community surgeon.
Agree.
Yeah, I feel like there's still numerous, people out there in the community or whatever that are just based still off PI minus LL, right? And they
Well, it's hard, right?
Right.
It's hard to like measure all this. It takes time. A lot of people don't have an EOS or maybe aren't up to speed, So that I think is a huge challenge, and maybe we all can work towards trying to make it more accessible for everyone.
So your point and subpoint, I think, are a paradox. So they they don't go together, right? You can't have PIL mismatch less than 10, SVA 4, PTA 20, and Lucille. Like they don't work together. They work because one is a locked point.
Yeah.
And then Rusali is more like a dimmer switch. Like you're moving a line. You can actually see the whole like alignment change as you're working your way through it, right? So, I would say like definitely be more on the fluid side.
Yes.
However, I would be interested to know like what OIT is teaching, like what they want you to know, because I wonder if they're still on that.
I think
on your bold line, like
there is, still a pretty heavy emphasis on the more historical stuff.
Okay. So it's
Yeah, the
important to
board,
remember. So like, make sure you take that home with you. Like not like
MOC
moving the
still
whole thing.
MOC still on it, Greg.
I know, right? It's crazy to me.
So yeah, it's a problem.
Our orthopedic board recertification is still big on this. It's crazy.
But I mean, in what was it, the IMAS survey, I think Dr. Munder surveyed the audience and a third of them said they still use PIL as their
target.
And a third of them said they don't use any target, they just look at it or something.
Yeah.
Right. And then
Honestly, every meeting I go to, they say PILL.
Yeah.
Like I feel like that's what the vast majority use still.
You go into the room with ISSG and you talk to the MIS surgeons, they still use it.
Yeah.
Yeah. Well, hey, I wouldn't be too negative about it. It's better than nothing. It's better than what used to happen, which is people just locked folks into flat back. It probably is, in a crude world, it's reasonable for the main group, but not the peripheral Russellis, and it's just not widely precise enough. So, I look, we got to move people in the direction of greater accuracy, but as a starting point, it wasn't bad. It was much better than when I trained, which was when we just threw people on the table and locked them in to these pretty grave deformities and really had no guidance on where to position them. So historic, helpful, iterative, but we're getting better, I think.
Yeah, Bob,
for sure.
I'll second that too. Yeah, remember the old techniques of spinal fusion? We were doing pliffs, with patients, hips flexed on tables that, we were creating kyphosis. We were locking them into flatbacks. We had no clue. So it is a huge change now, just to be aware of it.
Awesome. 7:30. Guys, have a great week. Thanks, Kenny. Good job.
Thank
Well
you all.
done.
I appreciate it.
Well done.